Fundamentally speaking, the heart is a great big left ventricle. And that left ventricle is best described as a great big inverted muscular cone. And we'll divide this cone into 4 quadrants, each one getting its anatomical name: the anterior, the left lateral, the posterior, and the septal quadrant. Comparatively speaking, the right ventricle is a much smaller muscle and is really less important into the entire process. It's a muscle that barely moves. So for all intents and purposes, we're going to say that the right ventricle is pretty much an after-factory add-on. Now I just flipped our perspectives. We're now looking at that heart from the back. The right ventricle is now on the right side of the screen. The left ventricle is in the center of the screen. We're looking at the posterior surface facing us. But notice I'm changing the posterior area here. This part of the posterior area is not referred to as the posterior. And the reason we don't call the bottom 1/3 of the posterior region, is because this is the one spot that the inferior EKG leads can see when they're looking up at the base of the heart. More on this later. But realize that the bottom 1/3 of the posterior is referred, and by extension, parts of the right ventricle, is referred to as the inferior. Now we're back to the anterior view. The patient's facing towards us. On our right, we see their left lateral surface. The anterior surface of the heart is facing towards us. Now we're going to talk about how each of these surfaces of the heart are perfused by the coronary arteries. The coronary arteries run on the outside of the heart, what we call the epicardial surface. The major artery of the heart, the one that delivers about 85% of the blood volume to the entire heart, is the left main coronary artery. This artery originates from the aortic artery. It originates from just above the site where the aortic valve let the blood out of the left ventricle into the aorta. Travels a very short distance. Now, because it travels just a short distance, don't think it's a small artery. It's about the diameter of a soda straw. As soon as it pokes its head out from underneath the right atrium, this large artery bifurcates. We have one arm of that bifurcation going anteriorly and going up to the anterior surface of the myocardium, and goes down along the myocardium and then eventually wraps up right around the little apex. Perfuses the anterior surface of the heart. And not only that, but feeder arteries then go into the septum and will feed the 2/3 of the septum. Let's go back to that bifurcation. Right where the left main artery poked its head out from underneath the left atria, we had a bifurcation. One went to the left anterior descending, and then it bifurcated and went to the lateral side. This bifurcation then is referred to as the circumflex branch. The circumflex continues all the way around the left lateral margin of the heart. It will assist in perfusing the posterior region. Now to the right side. The right coronary artery, or the right main artery, again originates at the aortic artery, just above the site of the aortic valve, where blood came out of the left ventricle. It traverses across the anterior portion of the left ventricle, goes over to the right ventricle, perfuses the right ventricle, and then wraps around to perfuse the back of the heart. At that point in time, it's going to become known as something else. We'll talk about that in just a moment. Another important fact about the right coronary artery is as it's passing the right atria, it perfuses the right atria. That's going to become important in just a few as well. There's 2 other arteries I'd like to mention before we move on. The first one is over on the left side of the heart, on the left ventricle. Branches off of the circumflex branch, runs down the left lateral portion of the heart, perfusing much of the left lateral portion. We call this the left marginal artery. In a like manner, there's a marginal artery that branches off of the right coronary artery, runs down the right ventricle, perfuses much of it. So now we're back to the posterior view of the heart. That right coronary artery wrapped around the right ventricle, went to the posterior side of the right ventricle, and came over to the posterior side of the left ventricle, proceeded downward. When it proceeded downward, it perfuses the entirety of the inferior surface of the heart. It also contributes into the feeding of the posterior surface of the left ventricle, and it perfuses inward towards the septal area. Feeder arteries will go in and perfuse about 1/3 of the septum. So now that we see that the septum is perfused by two arterial sources, and that's fortuitous because the septum differs from the rest of the myocardium for this simple reason. It carries all the conductive structures that send signals from the atria down to the ventricle, assures that our heart beats in a nice in syncytium beat. This is very important. I detailed the coronary circulation with simple line drawings as an attempt at clarity and to define the circulatory patterns in an orderly manner. Now let's look at it in a diagram that's a little more realistic. Remember, the heart is a large left ventricle. A major bulk of its perfusion comes from that very wide yet very short left coronary artery. As soon as that artery emerges from underneath the left atrium, it bifurcates. The left anterior descending artery perfuses the anterior surface, and there are feeder arteries off of the LAD that perfuses the septum. We can expect that if there is a thrombus in the LAD, the anterior surface would become ischemic, and because the septal circulation relies on the LAD, there should also be septal involvement. So, depending on where the thrombus is and how much collateral circulation exists, frequently the septal and anterior surfaces infarct together. If there is a thrombus that occurs in the circumflex branch, we frequently see left lateral ischemia with an extension towards the posterior surface. However, if the thrombus is in the left marginal artery, the ischemia is often confined just to the left lateral surface. If there is a thrombus that forms in the left main artery, well, circulation is deprived to the septal, the anterior, the lateral, and the posterior walls. This size of a heart attack, whoa, very dangerous. Because of the level of involvement, it's referred to as the extensive wall myocardial infarction and has a high mortality rate. Moving over to the right side now. The right coronary artery also originates from the aortic artery. It runs along the edges of the right ventricle. As it passes the right atrium, it sends feeder arteries into it and perfuses the important structures that it contains, the SA node, the AV node. As it wraps around the right ventricle, it perfuses the right marginal artery that provides blood to much of the right ventricle. Then it will continue on to the posterior and the inferior region of the heart. As the right coronary artery reaches the back, it becomes known as the right posterior descending. It's the predominant artery that perfuses the inferior surface. It also acts as collateral circulation, providing blood supply to the posterior region and to part of the septum. One last takeaway. The coronary arteries lay on the epicardial surface, the outside, and perfuse through the myocardium towards the endocardial surface, the inside. A partial blockage of the coronary artery will affect the endocardium because the partial blood supply perfuses the first tissue it encounters, the epicardium, leaving little of that remaining blood supply for the last tissue that it's going to encounter, and that's going to be at the endocardial surface. Because of this, most heart attacks from partial blockages will originate deep underneath the myocardium at the endocardium. This concludes our lecture on the coronary perfusion. I hope you enjoyed it, and if need be, please come back and view this again. I hope it's beneficial. These are important lessons that we're going to need moving forward in interpreting the EKG, understanding why myocardial infarctions happen as they happen, and it sets us up for when we learn the 12-lead EKG. It'll be so much more understandable if you understand how the heart perfuses.